I'd like to introduce our speaker, Dr. Tamika Burrus. Dr. Burrus is a fellowship-trained vascular neurologist at Norton Neuroscience Institute. She works as a neurohospitalist. She has expertise in telemedicine, hospital stroke systems of care, and lifestyle medicine. Thank you for joining us today, Dr. Burrus.
Hi, everyone. Can you hear me? All right. So today we're going to talk about stroke diagnosis and management. I don't have, any relevant disclosures. And the goal of today's discussion is really to discuss the why behind current strategies in stroke management. Next slide. All right. So, the slides are very jittery. So the first case, we have a 54-year-old female. She has a history of diabetes, coronary artery disease, dyslipidemia, and hypertension. And she came in with a blood pressure elevated in the 180s with an NIH stroke scale of about 3. The NIH stroke scale is to the right here, and I just wanted to point this out. It's the scale that we use in the stroke world to essentially describe to each other throughout the country and the world, actually, how severe the patient's symptoms are or signs are. And it is limited, and that's what I wanted to point out, because many times you'll see your patient in the outpatient arena and it may say, oh, the NIH was low, but it's limited. As you can see, the scale really avoids or ignores strokes that are in the posterior circulation. It ignores strokes that are predominantly, It ignores strokes that are predominantly right middle cerebral artery strokes, as well as strokes where patients have very subtle symptoms. And so that's why I point this out. And this patient, as you will see, it was on aspirin for the coronary artery disease. There we go. So here we see a CT scan, 4 of them. And in the upper right-hand side, we see a non-contrast CT scan of the brain. And we see here this left thalamic stroke. And that's what this patient had, actually. And I also show this hemorrhage here in the cerebellum, as well as the pons and the basal ganglia. And the point of that is to show that we have these deep penetrating arteries that can rupture in patients that present in this manner. So what is the number one cause of intraparenchymal hemorrhage? Well, it is high blood pressure, which our patient had. So the question that you may be presented with in the outpatient arena, can we restart antiplatelet therapy? Well, hopefully the patient was seen at Norton by myself or one of my colleagues, and we've already restarted it, but sometimes for various reasons that doesn't happen. And so you may be presented with this question. And so there was a trial, a prospective randomized open-blinded trial that occurred in the United Kingdom. They looked at 122 hospitals, about 537 patients who suffered an intraparenchymal hemorrhage while taking an antithrombotic agent. So very similar to our patient who was on aspirin as an antiplatelet agent. In the trial, they randomly assigned the patients to either antiplatelet therapy initiation or strict avoidance. The trial generally started about 76 days after the patient's index event. And the physician or practitioner could have the patient on aspirin, dipyridamole, or even clopidogrel. And it was started within 24 hours of randomization. And so the primary outcome was recurrent symptomatic intracerebral hemorrhage, and fatal or non-fatal, radiographically proven or pathologically proven for up to 5 years. And the secondary outcome was looking at major vascular events, grouped as either occlusive or hemorrhagic events that occurred up to 7 years. And so when we look at the actual data here, we saw that there was a lower rate of the primary outcome recurrent symptomatic intracerebral hemorrhage here, identified between the groups, but it didn't actually reach predetermined measures of statistical significance. But in the stroke world, we felt it was pretty good. And so with that conclusion, we decided, based on this trial, there were no significance in rates of hemorrhagic recurrence in patients on antiplatelet therapy versus patients not on antiplatelet therapy. There were also no significance in major vascular events avoiding antiplatelet therapy versus resuming. And this was the first randomized trial on starting long-term antiplatelet therapy following intraparenchymal hemorrhage. They did have 100% follow-up in this trial, which was by the primary care physicians at all time points, 6 months up to 4 years, predominantly through mail. And so with that, we can feel reassured that it's okay to start antiplatelet therapy in those patients that you're seeing in the outpatient arena. So then our next case is a 58-year-old male with no past medical history, also came in with elevated blood pressure in the 170s. We're in the emergency room. Last known well is 4 hours. The patient has an NIH of about 12 or 13, essentially presenting with left facial droop, left-sided weakness, and ignoring their body essentially on the left, as well as slurred speech. And here we have this non-contrast CT scan, 2 different cuts here. This is the left, this is the right, left, right. And for the most part, this is a normal scan. And so the question is, the CT scan is negative. Did the patient have a stroke? The answer is yes. And so the main point that I wanted to make here is, because oftentimes we'll hear our colleagues say the CT is negative, patient didn't have a stroke. And so I just wanted to reiterate, the whole point of a CT scan is it's helpful to evaluate for trauma, bleeding, something large or old. And it is the scan of choice in acute stroke care because it's so quick. And when you're losing 2 million brain cells in a large vessel occlusion, we want to be very quick to decide on whether or not the patient needs thrombolytic therapy. So thrombolytic therapy, as you can see, looking below here at the STEMI data, and then above here, the stroke data, we're lagging behind our cardiology colleagues, but the muscle is very different from the intricacies. And while the heart supports the brain in its unforgiving nature, we can see that our cardiologists started using TPA or alteplase in sort of the late 80s. And then we began using it in stroke with the pivotal NINDS trial in the mid-90s. And so basically that trial showed that TPA was both safe and effective, treating up to 30% of patients who would present in the emergency department with acute stroke in the first 0 to 3 hours. The FDA only approves TPA for 0 to 3 hours. However, nearly every stroke center in the world utilizes it up to 4.5 hours. And also some of the centers will do it for patients with wake-up stroke or even in an extended window in select patients. And I mention this because, you know, if your patient presents to you in the outpatient center and they're outside of the window, or they say they woke up like this and they just come to your office, it really is important to just have them call 911 from there, because if it's below 24 hours, we may have treatment that we can still offer them. And so just to ensure we're all on the same page here, it looks like one of the slides didn't really show up, but essentially just a reminder that we all have endogenous TPA and exogenous TPA, which is essentially alteplase that I was just talking about, which is a recombinant TPA, but we also have tenecteplase, which we've known about since about 2005, and our cardiology colleagues have certainly been using it, and we've been lagging. And I apologize, I don't know why the image isn't showing up, but tenecteplase essentially is a genetically modified alteplase. And with tenecteplase, you have amino acid changes at both the T, N, and K site. And essentially, that's where the name TNK comes from. Tenecteplase is also a TPA. And so it's important to realize that they're both TPA. And so the question is, that patient that's coming in, should we as an organization switch from alteplase to tenecteplase? One of the things that happens in the emergency room department when your patient's sent there is they undergo a very complex administration of alteplase. The nurses have to draw up 10% of the medication and give it as a bolus. Then it has to be given as an infusion over an hour. And then they have to piggyback that with IV fluids to make sure all of the medication that was in the line was given. We've seen some delays throughout the country and world with the time the patient gets to the emergency department and the time that they actually receive reperfusion therapy. Some of that is because you have to have 2 IVs with alteplase. And as I kind of alluded to, the dosing is not very simple. And also a lot of patients are coming from outside hospitals, smaller hospitals. And so there's a delay with transferring them from those hospitals to a larger center because alteplase has so many different things that you have to deal with. And so there is a trial outside of Canada, the ACT trial. This was done because previous trials had been looking at alteplase versus tenecteplase dosing, really following again that cardiology literature, which we found at the higher doses was too much for the brain. And so this was a multi-center trial, open label. They looked at 22 primary and comprehensive stroke centers. It was a nice trial because they used similar inclusion and exclusion criteria that we already use for alteplase, and they had fairly good randomization. And so in this trial, the baseline characteristics of the patients, mainly the silver tsunami, so people in their 70s and so forth. Half of the patients were male, and they were what we would call moderate NIH stroke scale, so that scale that we showed at the beginning there. About 25% of patients did have a large vessel occlusion, and the majority of them actually were seen at a comprehensive stroke center. Part of that was because most of the trial was done during the height of the COVID pandemic. And so that was easier for the hospitals with the other burden of patients that they had. The door to needle, interestingly, was about the same in both the tenecteplase group and the alteplase group. And that was a bit surprising, but I wonder if that was just because it was in the context of a clinical trial. And so looking at the efficacy outcomes, we can see that looking at modified Rankin score, which is what we use in the stroke literature to really tell us, is the patient having a lot of disability or not? The lower the number, the better. So a score of 6, which is the highest, is death. And so 2 is slight disability. And so we can see when we compare the two groups, the tenecteplase group to the alteplase group, there really is no difference. And so that was reassuring. And of course, the main thing that people get concerned about when using any of these thrombolytic agents is safety. And so also comparing the safety, looking at death within 90 days versus symptomatic ICH, we can see it's fairly well matched in both the tenecteplase group and the alteplase group. And so in summary, the main point of this trial was that non-inferiority was established. And this trial, which occurred just a few years ago, last year's when the results came out, is the reason why so many centers now in the world use tenecteplase as their thrombolytic agent of choice for acute ischemic stroke. And so why is this relevant to you? Well, we've just met our stroke group, and we are going to be moving towards tenecteplase at the beginning of 2024. And so I wanted to make sure you guys were understanding of why and sort of the data behind that. Seeing here the potential benefits, possible decrease in medication errors. A lot of people, in particular our ER doctors and us as well, are very concerned about bleeding risk. And so tenecteplase is more fibrin specific than alteplase. And so there is a theoretical benefit of less bleeding. The lower transfer times is a potential, especially in the Norton system, where we have so many patients being transferred in. I think it's going to be really helpful for staffing. And then you only need one IV because you push it over 10 seconds because it's such a longer half-life. And the dosing is very easy. It's just going to be 0.25 milligrams per kilogram. Now, unlike alteplase, which we can return if for some reason, as we're administering it or right before we've or after we've mixed, the patient is no longer a candidate, we can't give it back and be reimbursed. Another thing is that there was a recent study that showed that patients with tenecteplase do better with mechanical thrombectomy than patients who received alteplase prior to mechanical thrombectomy. Now, the reason why that matters is because back to our patient, just to give you an idea of what happens on the back end. So as stroke neurologists, we're essentially receiving a phone call from our ER doctor saying we have an acute stroke. You know, it's 2023, so we get on our phones and there's an app. And in the app, there's a AI program that helps calculate, is this a patient who has brain to salvage, or what we call penumbra, which is the whole goal of thrombolytic therapy. And so even though the non-contrast CT scan will be normal in many patients, when we look at this, which is called rapid or their CT perfusion, we'll see an abnormality. So in this top panel here, this purple really tells us brain that has already died. And then the green is tissue at risk. And this is really the goal of reperfusion therapy and revascularization. Versus below here, they're pretty well matched. And so this is a patient that would not be a great candidate for, say, mechanical thrombectomy. Although we still give alteplase or soon tenecteplase in these patients, as long as their CT scan is negative and they meet other criteria. And I sort of alluded to this already. There was a recent trial because in our patient, they did have a large vessel occlusion, which we kind of knew because their NIH was a bit higher. And the trial showed that there's a 3-fold higher odds of achieving successful recanalization if the patient received tenecteplase versus alteplase. So back to our patient. Here we have our basic stroke workup. And I point this out just to highlight a few things that sort of come up. So number one, carotid Dopplers is in bold. And the reason is because we sometimes see that patients are getting carotid Dopplers, even though in the emergency room for probably 95% of our patients, they've already gotten a CTA of the head and neck. And so the CTA of the head and neck is a lot more sensitive than the carotid Doppler. And unless a vascular surgeon wants to see it, or the patient has a known stent in their carotid artery where we need the carotid Doppler, there really isn't great utility in ordering that test. In our patient, they had a right M1 occlusion, and they also had an anterior circulation aneurysm. They had an echocardiogram, which showed no PFO. Their cholesterol was high at 127, and they have a hypercoag pending. Now, I mentioned this hypercoag pending because it is something that is traditionally done in patients that are below the age of 60, which our patient was. So by definition, considered young. But a lot of times we will see that people are ordering protein C, protein S, factor V Leiden, but no, our patient did not have a PFO. And those are things that are really looking at venous etiologies of thrombosis. And so not necessarily relevant in most patients who don't have a PFO. So our stroke in the young, because the patient's sort of young, really is just making sure that they haven't used cocaine or methamphetamines, and that they have a basic sort of infectious workup. Antiphospholipid does come up a lot in patients. And so the initial screen of that, which then has to be repeated in the outpatient clinic. And so I bring this up because just a reminder that the patient has to have a repeat test 12 weeks after the initial test in the hospital setting. And then, of course, cancer screening in certain patients as appropriate. So our patient did have a very high LDL. And so for a long time, we weren't sure exactly, well, what is our goal LDL in these patients? And so the AHA guidelines just said do high dose intensity therapy based on the Sparkle study done many years ago, but we don't know exactly what our target is. And what we saw is that a lot of patients, when we looked at the TIA registry data, after 5 years, they were discharged and they had an LDL of say 119. And then after 5 years, the LDL was 92 and patients were still having events as well. So there was a clinical trial recently called Target Stroke to Treat, which aimed to look at this. Is there benefit in giving patients an actual target versus just saying high dose? Because another thing that we saw with the TIA registry data is that a lot of times patients would go to their outpatient provider and then their statin would be lowered, even if the LDL was still elevated. And so what this trial did was to take patients with ischemic stroke in the prior 3 months or high-risk TIA, so they had to have motor findings like a weak arm or leg or a speech change for at least 10 minutes. And the purpose of that was really to try and eliminate stroke mimickers or TIA mimickers. And the TIA had to have been in the prior 15 days, and they had to have documented atherosclerotic disease. And so the patients also had evaluation looking at the aorta as well, and a clear indication for a statin. If the patient already had an LDL less than 100, or if they were already on maximum treatment, or if they had a history of ICH, they were excluded from the trial. And so patients were randomized to the lower target group, so LDL less than 70, versus the higher target group, so LDL of 90 to 110. And they did a 3.5 year median follow-up. And as you can see, 8.5% of patients with the primary endpoint of major cardiovascular event in the lower target group versus 10.9 in the higher target group, with a fairly significant p-value there. And so they did see a higher number of ICH, but it was proven to not be insignificant. And as I just mentioned, a lower value or risk of cardiovascular events in patients whose LDL target was less than 70. So when you're seeing your patient in the outpatient clinic 3 months after their stroke, and we've got them on 80 milligrams of atorvastatin, please, before trying to lower that, make sure that their LDL is at the goal of less than 70, just to help them. So then the question is, we've taken care of our statin. What do we do about antiplatelet secondary prevention? So the adaptable trial recently with our cardiology colleagues looked at this about 2 years ago. And what they looked at is in patients with established atherosclerotic disease, aspirin 325 milligrams does not lower the risk of death, stroke, or myocardial infarction compared with 81 milligrams. And so the other interesting thing in the study is that patients tended to stop taking the 325. They weren't exactly sure why, and switching themselves to aspirin 81. So that confounded some of the results, but it also let us know that there was a strong patient preference for a baby aspirin. And so unless there is a cardioembolic reason for anticoagulation or so forth, aspirin 81 really is enough. And so from the 1800s to now, that's our big medication. So then in our patient, aspirin 81 is enough, but you may notice that some of your patients are coming in to see you 2 weeks after they've been seen in the hospital setting with a diagnosis of a TIA or a stroke on both aspirin and Plavix. And so the question came a few years ago among patients with a transient ischemic attack or stroke, does dual antiplatelet therapy confer any benefit? And so this was a Chinese study called CHANCE, where they demonstrated in a Chinese population, so a lot of intracranial atherosclerosis, is the combination of aspirin and clopidogrel for 21 days, followed by clopidogrel monotherapy, superior to aspirin alone. And they found that it was without a huge difference in bleeding rate. Other trials, in particular Point here in the United States, found that although there was a decrease for stroke, there was an increase in in major bleeding risk. And so there was a meta-analysis that was done that looked at patients with aspirin and a P2Y inhibitor versus aspirin and placebo. And as you can see, if the patient had a minor stroke, which was not the case in our patient, so that's why our patient was just on baby aspirin, or a high-risk TIA, short-term dual antiplatelet therapy does confer a benefit. Of course, there is a risk of some GI bleeding, but in the stroke world, this is considered a positive. And so for most patients that we're seeing in the ER or the inpatient setting, we are having them be placed on both aspirin and Plavix or clopidogrel. So aspirin 81 is best for most patients, and in minor stroke and high-risk TIA, it may be appropriate for the patient to have both. So talking about our patient again, so the question is why did he actually have this large vessel occlusion? He had a clot in his right MCA. He didn't have a patent foramen ovale. He did have elevated cholesterol, but he's young-ish. And so what we do is we usually send a patient home with an event monitor, although we do know that this is generally not going to pick up atrial fibrillation. And so many patients, we recommend a loop recorder that's implanted. It's a 5-minute procedure that happens in the cardiology outpatient clinic. And that's what we did with this patient. And lo and behold, he had AFib, so he was placed on Eliquis, which is the agent of choice in patients with AFib for prevention of acute ischemic stroke. And so the patient, remember, he had that unruptured aneurysm, and it was 2 millimeters, and it was an ACOM aneurysm. And so we've had this data for a long time, and so I wanted to just point it out just so that you don't get anxious in the outpatient clinic. So what we're looking at here is group 1, essentially in this trial, was looking at patients who did not have a history of subarachnoid hemorrhage or ruptured aneurysm, and group 2 is patients who did. And we see that less than 7 millimeters, if it's anterior circulation, which was our patient, there's pretty much no risk of rupture. And so for the most part, of course, send these patients to see our neurosurgical colleagues or our colleagues in vascular neurology as outpatient. But for the most part, we're just going to monitor them with serial MR angiograms just to make sure there's no growth. And the best thing that you can do as a primary care provider is no smoking, and of course, strict blood pressure control. So life happens and our patient turns 45. So I meant to put 35 for the initial age for him. But at any rate, he needs a colonoscopy. And I bring this up because this also comes up, and this is more anecdotal, what we see in the hospital setting. So we'll get a consult for a patient who's having an acute stroke, and they were going for a colonoscopy, and they were on Eliquis, and their anticoagulation was stopped for a week, and that's really not necessary. So we do have a site that our pharmacy team has put together, looking at all the data, and based on what procedure the patient is getting, it tells you when to hold anticoagulation and for how long, and when to resume. And so in this particular patient, and this is just a screenshot from our site in the Norton intranet, he's getting a colonoscopy, so that's low risk, and he's on apixaban or Eliquis. And so essentially you can see that we just need to hold 24 hours prior to the colonoscopy, and that's it. And so I just wanted to remind you guys of all of this. Now, in case the timeline of thrombolytic therapy didn't convince you, in the stroke world, we are slow to adapt things at times. So it's 10 years later from today, we're probably still going to be doing the same thing. And our patient develops slowness of movement, a tremor, he's falling a lot, he develops Parkinson's, he's got some dysautonomia. And primary care, IEU, wants to know, hey, this patient keeps falling. There's debate about, whether or not patients should be taken off Eliquis for that alone. But at any rate, everyone's feeling very nervous about this, having a patient on Eliquis who's falling a lot. And cardiology agrees. But remember, our patient has a really high CHA2DS2-VAS score, and so high risk of stroke. And so the question is, among patients with non-valvular atrial fibrillation, is percutaneous left atrial appendage closure non-inferior to warfarin? Now, this patient's on apixaban, but it still applies. And so I just want you to remember this when you're in the outpatient arena and you have a patient who has some contraindication to the anticoagulation they're on, whether it's because they have alcohol use disorder or falls or something else. They may have really bad dementia related to cerebral amyloid angiopathy, for which we would not want them on anticoagulation. That we do have a procedure that our cardiology colleagues can perform called the Watchman device that can be placed. And this should only be in select patients. And I only put this up just as a reminder that this is something that we don't want to forget about. The trials around it do have mixed results, and that we are seeing some ischemic stroke more in patients that are treated than patients that aren't. That tends to be peri-procedural, and we'll see how that plays out, but it might be something worth considering in select patients. So in conclusion, what do we have here? We have CT scan does not rule out ischemic stroke, very important. Tenecteplase is not inferior to alteplase, and that is what we're going to be using in the Norton healthcare system in the next coming months. There's no significance in hemorrhage recurrence and restarting antiplatelet therapy in patients who had an intraparenchymal hemorrhage, most likely related to high blood pressure. And so don't be shy about doing that if for some reason that wasn't started in their inpatient stay. There's no need for carotid Dopplers if a CTA of the neck was done already in most patients. Stroke in the young workup, if the patient's under age 60 and they have unclear etiology, understanding that a lot of the times it's that they have underlying atrial fibrillation. Dual antiplatelet therapy, 21 to 90 days in select patients. Aspirin, our wonder drug, is usually what we give most patients. Unruptured aneurysms that are small just need to be followed, so there's no need for an urgent consult about that. And the implantable loop recorder can be helpful more so than a Holtered or extended event monitor, or even the Zio patch, which really is a patch that's just placed for 14 days and is most helpful for your anxious patient who's having tachycardia, just to say, okay, that's not an arrhythmia. Controlling blood pressure is the most important thing, and really food is medicine. And so I think it's really important to reiterate to all our patients that the only diet that's been proven to prevent stroke is the Mediterranean diet. And if you go to Norton Healthcare's peri-op anticoagulation management document, you can see that on Insight. Go to departments and lab, and then it's in the bottom right-hand corner, the peri-op anticoagulation management. It's a wonderful 20-page document that our pharmacology colleagues have done an excellent job really distilling down the data, and they just updated it this month, so it's hot off the press. And with that, I'll take questions. I don't know how to.
Thanks a lot. So I think you really presented a lot of good information. I know we have one question in the Q&A box, and I wrote down a couple during your presentation. So question from the participants: when dealing with significantly elevated blood pressure in primary care, at what point or level of blood pressure would warrant an ER visit versus adjusting medicine in the office with close follow-up if the patient?
Yeah, such a difficult question to answer, but an important one. I guess from my standpoint, from a neuro perspective, if the patient's presenting with elevated blood pressure and they say they also had the worst headache of their life, I'm going to send them to the ER regardless, because that could be a subarachnoid hemorrhage, and we cannot miss that because that has very high mortality if we're not able to fix that aneurysm right away. If the patient is having any focal neurologic symptom, that could be a stroke or a TIA, or if they had a history of prior stroke, a recrudescence of that prior stroke. I'm not going to play around with that either. If it's simply just elevated blood pressure without any symptoms or signs, then I think you could just, adjust their medication, see if it goes down, and assuming, they're not having chest pain or anything like that. Oh yeah, it says assuming patient's asymptomatic. Sorry about that. I didn't. So I would say, for most people, as long as it depends on what their blood pressure was at home and what they live at. So that's also an important point. So it's going to vary patient to patient. I don't think we can really say it's the same for every patient, because some people live at a very high blood pressure. And then if there's any type of confusion, definitely send them to the ER, because they could have posterior reversible encephalopathy syndrome, especially in our patients with renal disease.
Thanks. I appreciate that answer. So a question I wrote down. So you talked about using the 81 milligram aspirin, and then the dual antiplatelet therapy in certain situations. What are the indications, or are there indications for us to use something like the clopidogrel or one of the prescription antiplatelets instead of aspirin? Is there, because I know that I have had patients in the past that that aspirin seemed appropriate, but they ended up on a prescription antiplatelet.
Yeah, excellent question. So, we've looked at that data, and there's really no benefit aspirin versus Plavix, if that's what you're saying. And we know, as I mentioned, dual antiplatelet, in select patients only. So if the patient has really bad intracranial atherosclerosis, then that's going to be a patient we're going to have on for 90 days versus someone for 21 days of minor stroke or TIA or high-risk TIA, so ABCD2 score greater than 4. I know sometimes physicians feel better, myself included, if the patient came in on baby aspirin, they had a stroke, definitely don't increase it to 325. There's no benefit at all to that. Only increases your risk of GI bleeding. I mean, in Europe, they use 50 and 70 milligrams for the same disorders. But if patients are coming in and they failed aspirin, meaning they had an event while on aspirin, it really depends on the neuroimaging for myself. So if it looks like their strokes are mainly cortical based, and some patients, if they've been having a lot of them, even though the evidence doesn't support this, I will do a 30-day trial of anticoagulation with Eliquis while having them monitored, and then reevaluate every 30 days because I don't want them to have, a major stroke. In other patients, in particular, you have to pay attention in our Asian population, if they're on Plavix. Hello? I don't know what happened.
We can still see and hear you.
Oh, something happened with the screen, sorry. So it's fine. If the patient is on Plavix, in particular in Asians, some of them are resistant, so you'll have to check and make sure that they're a responder or not.
Okay, and the final question from me is about genetic testing. I know that based upon certain looks on the imaging that like CADASIL is one thing. When do you look for more of those esoteric type conditions? Is it purely based on imaging or symptoms and imaging, or how do you differentiate?
Well, in neurology, and I guess most medicine, but in particular neurology, history is so important. So, if the patient, for instance, with CADASIL, autosomal dominant Notch3 mutation, if patients are having, oh, my brother and sister or somebody else had stroke at a very young age. And then when we're looking at the imaging, if there's a lot of subcortical ischemic changes, and they have more of a shuffling gait and maybe dementia or something like that, and they keep having strokes and no one knows why. So in that patient, I would evaluate for that. In your female population, I'd have a low index of suspicion, especially if the patient has other autoimmune conditions, to look for vasculitis or a vasculopathy that could be causing stroke.
Thank you.